Good morning. Welcome to all of you. Thank you for being with us. I am Norbert Claude Gorin from the Department of Hematology at Hôpital Saint-Antoine in Paris, and I am the chair of the EBMT Global Committee. I am pleased and I am honored to be the moderator of this seminar dedicated to COVID. It is our fourth seminar. You may think it is dedicated to COVID again, but unfortunately, yes, because the pandemic is not over. So these are my disclosure for this presentation. And I want to repeat that this webinar is supported by an unrestricted educational grant from Air in Space. So this is the program we will have. I will present a short introduction, and immediately after, we will have three very distinguished and renowned speakers. The first one is Professor Livio Pagano from Roma. He has been the chairman of the EORTC, Infectious Working Party, and he will report on an international survey, which is called the EPI-COVID EHA survey, which involved 132 centers in 34 countries and brought to our attention interesting data on about 4,000 patients. The second speaker is Professor Olivier Schwartz, who is the head of the Virus and Immunity Unit at Institut Pasteur in Paris, and he will tell us about the so many variants of the COVID, and he will also tell us how we are protected by vaccines against these variants, including the Delta variant. And the third speaker is Professor Per Ljungman from the Karolinska Institute in Stockholm. He has been for long the head of the Infectious Working Party of the EBMT. He is an international expert recognized for cytomegalovirus infection, so he will give us some recent news, but in addition, of course, he will speak also about the COVID. And please, at the end, you see we have the Q&A session. We will ask questions and we will have half an hour. So my short introduction is to tell you again what the situation is or was on November the 18th. The global number of infected people is around 255 million. The death rate of 2% means more than 5 million deaths. But I think the most concerning thing is that every month we are adding about 200,000 deaths. And the total number of vaccine doses administered so far is impressive, more than 7 billion, but still the virus is here. So how can we protect us against the vaccine? Of course, the first is prevention. I already showed in the past this slide. HEPA filters, this one are modified because in addition to being HEPA filters, they also destroy all particles, including viruses, in an oxygen plasma-built environment. This is a picture I took several years already ago in Suzhou in China, and also, for instance, this BioCare room, a picture taken in Shanghai in Beijing, and these rooms have the a specific tool. The pressure inside can be switched from negative to positive. But about the vaccines, and so to speak, to introduce the talk by Olivier Schwartz, I'm presenting here many targets that can be used to aim at when building viruses, but we will hear Olivier Schwartz. And finally, of course, the most interesting thing today for us would be drugs, therapy, direct therapy to block the replication of the virus. So this is a deception. I'm starting with an in vitro study that you may remember, which showed that the viral titer of the replication is reduced with remdesivir and more even with the combination of remdesivir and opaganib. But unfortunately, it works in vitro, but not at all in vivo. And you have heard, or you may have heard, of course, that since the last months, we have now two new molecules. One is Paxlovid, and the second one is molnupiravir. The first one, if taken in the first 5 days of infection, meaning very early, reduces the risk of going to the ICU and the risk of death by 90%. And the second one, which has been recently approved in the UK, does the same thing, supposedly with a lower efficiency, but still very interesting, of 50%. So I am done with my introduction. Again, do not forget the Q&A session, and I will now ask Livio Pagano to present the data of his survey, and see you at the end.
Good morning, everybody. Today, I will speak to you about the problem of COVID infection in patients with hematological malignancy. And I want to show you the results of this large registry that we performed among a European Hematology Association group. These are my disclosure, and then we can start. We can start from the literature that is very rich of great large multicentric studies that were published during 2020, but the majority of these studies were focused on the first wave of COVID, and they reported in all cases an incidence and is not reported the incidence, of course, but the mortality rate was very important, 25%. If we consider all these studies. But as I already say, is based on the first wave, in the first months of this kind of infection in these patients. And from March 2020, we started a survey with a registry that enrolled all cases until December 2020. We have an electronic case report form, and we collected cases that were enrolled by, above all, European centers, but also from not European centers. Overall, we have 132 centers in 24 European and non-European countries that participated to this survey. The results that we have already published just in these days on the Journal of Hematology Oncology, said us that we collected 3,800 valid cases. Of course, considering that we are in Europe, the majority of centers are all Caucasian patients. The median age of these patients was 65 years old. And as you can see in this picture, the majority of them are older than 50. And there is a prevalence of male sex, near 60% of these patients. Regarding the kind of infection, I want to underline that we have no, the denominator is impossible with the large number of cases, and also for a lot of problem, how many patients are on treatment. We must consider also patients that are treated in the last years. So we have not the denominator. We can, but we know that the majority of patients that developed COVID during this period of observation are patients with lymphoproliferative disorders, near 70%, above all non-Hodgkin lymphoma, chronic lymphocytic leukemia, and multiple myeloma. As normal, because these are the malignancy most frequently observed in our patients. But I want to underline also that 30% of patients have an acute myeloid leukemia. It's a very important point. Regarding the comorbidities that we observed in our patients, near 70% of the patients have more than one comorbidity. And the most frequent comorbidity that we observed in these patients was a chronic cardiopathy, near 1/3 of these patients. 12% of these patients was smokers or ex-smokers. An important point that we must take in consideration. Regarding the diagnosis was performed in near all patients on the basis of a nasopharyngeal swab. But why our patients performed the test for COVID. It's interesting that 700 of these patients performed the test for screening. In the other cases, in the majority for pulmonary symptoms, 2,200 patients, and at least extrapulmonary symptoms was also present as diarrhea and moreover. So it is very important at this point that there is also patients that were completely asymptomatic, and when the patients must be admitted for treatment in the wards, they presented a colonization or an infection by COVID. According to China Center for Disease Control and Prevention definition, we stratify our patients for severity of COVID infection. As you can see, severe or critical disease was present in the majority of them. Few cases have mild or were asymptomatic, as you can see in this slide, 70%, 18%. And regarding the chemotherapy program, I want to stop a few time on this point. Only 500 patients did not receive any chemotherapy and was considered in complete remission and not in active treatment. In the other cases, all the patients received a chemotherapy in the last months or in the last 3 months. Attention regarding the approach. More than 1,000 of these patients received immunotherapy or immunochemotherapy, above all lymphoma, that were treated with classical chemotherapy combined with monoclonal antibodies. There is also a large number of patients that received a conventional chemotherapy, as you can see in this table, conventional chemotherapy in near 500 of these patients. And regarding the transplant, because also these patients were collected, it's interesting for this kind of patients that we have the denominator, because more easy. We consider also only the patients that received a transplant during 2020. Well, the incidence of COVID infection is 2% among autologous transplantation and higher among allotransplanted, 6.4%. And also, I want to underline, even if there is a low number of infection among those patients that were treated with CAR-T administration, we have 4.6% of cases. Regarding the kind of allotransplantation, we not found a difference between those patients that received a mood, a sibling or haploidentical transplantation, as you can see in the back of this slide. During duration of admission during the COVID, as you can see in these slides, the duration of hospitalization is median 15 days, but attention, this number of days could be very probably not real, because we included in these numbers also those patients that unfortunately died within a few days. So we take great attention on the duration of admission. More important is that about 24% of the patients admitted in the hospital needs of intensive care units, and among them, the majority of these 65%, as you can see here, need of invasive mechanical ventilation. Very important point. And so it is important because this data said us that these patients presented very aggressive complication. The overall mortality that we observed during the period of observation is 31%. We take in consideration also this data was attributable or contributable mortality, but while overall mortality is well defined, because it's easy, all patients that died during the observation. Regarding the attributable or contributable deaths is based on the judgment of the local physicians. So could be not real. Taking note of 31%. That is a light high with respect to those the mortality rate that was reported in the other large studies on the that I show you in the first slide. And the mortality was mainly in those patients with an age over 50. And arrive to 44% in patients older than 70. Near to that, we already observed in patients in general population. So is quite similar. But I want to underline that also patients younger than 70 have the risk to death. Regarding the hematological malignancy, it is interesting to observe that the mortality have a great variability between chronic lymphocytic leukemia that arrive at no more than 28%, and it reach high numbers, high percentage, above all among patients with acute myeloid leukemia, that is 40%, and patients with myelodysplastic syndromes, 45% for the high risk of these kind of patients. Take attention to this data because later I show you the actual data on after the start of a vaccination because something is changed. And when we analyze the overall survival in stratifying patients asymptomatic, patient with mild infection, patient with severe infection or critical infection, as you can see, is dramatical, the percentage of the death among those with critical disease, with a very significant level of death in this kind of patients. In fact, also this also is reported regarding the patients that needs of mechanical ventilation or that need admission is dramatically higher in those patients. 63% of patients that needs admission in intensive care, and above all, in those patients that needs mechanical ventilation in order to explain that this malignancy, this complication, independently from the malignancy, is very important when these patients needs of this approach. And the pulmonary complication, when the patients present pulmonary symptomatology, in these cases, the mortality is strongly. Regarding the treatment, the question is, have the treatment an important role in the mortality? It seems yes. Seems yes regarding the methylating agents that frequently we use mainly in the first wave, also for treating patients with acute myeloid leukemia in order to reduce the risk of prolonged neutropenia and prolonged myelosuppression. When we use the methylating agents, the mortality is near 60%. But attention also for the CAR-T. CAR-T in this preliminary report, in this report is near 47%. But we have increased the number of cases. We increased the number of the patients that we observed in a second paper that actually is in press on Blood Advance. And in this data, the mortality reached 50%. Sorry for the number that is not clear, but now we can say that if a patient with CAR-T developed COVID, the risk of mortality is dramatically high. Move on and arrive to the situation of the mortality in subgroup of patients that underwent a transplant procedure. These are the data from the major European group, the BMT and the British group, that say us that allogeneic autologous transplantation is a quite similar outcome with 24% of mortality. Is important point, and also in our experience on large number, we confirm that the mortality is not different among autologous allogeneic transplantation, and they arrive at near 25% of patients. And but interestingly, when we compared patients with transplant and with those patients that not received the transplant procedure, there is a significant difference in the outcome, better for those that underwent to transplant procedure, probably because we use for these patients a better approach, more attention for the treatment of this kind of patients. But in our study, we also analyzed the first and the second wave, considering the first wave, March, May 2020, and the second wave, October, December 2020. Well, in spite of an increase of a number of cases that were registered in the second wave, we observed a very important reduction, significant reduction of mortality in the second wave that arrived no more than 24%. It's an important point. And this reduction of mortality is confirmed to be in all the malignancy independently to the treatment, and moreover, there is a reduction of both for lympho and myeloproliferative disorders. Risk factors. Risk factors, there is a lot of studies that analyze the risk factors. This is the Spanish group that identifying acute myeloid leukemia comorbidities, antineoplastic treatment with monoclonal antibody as a factor that influences the mortality. And also the study from Italian group said us that older age, diagnosis of acute myeloid leukemia, and also lymphoproliferative disorder represent a very important point, and a severe critical COVID-19. In our experience, what we say, we observed that the age, the active disease, and above all, myelodysplastic syndromes and acute myeloid leukemia represent the at multivariate analysis the factors that highly impacted with the mortality rate. On the contrary, attention that a high number of lymphocytes, over 200, and a high number of neutrophils, but above all, a lymphocyte have a protective factor for this kind of patients. But the question is, COVID-19 pandemic ended in December of 2020? Unfortunately, no. And so we have a new target for our survey. We now included during all the 2021 until December 2021, all patients that in spite of vaccination developed the COVID, and those patients that developed the second episode of COVID. In this last part of my presentation, I will focus my attention mainly in those patients that received the vaccination. And we know that COVID-19 modify the response mainly in those patients that received chemoimmunotherapy that have a lower rate of seroconversion. And also this study recently performed show us that those patients with lymphoproliferative disorders in spite of vaccination have a low response. And in the real life, in our patients, how are the epidemiological data? I can show you the preliminary data during the second part of this registry. we increased the number of the participating centers that arrive at now are 162, and the participating country that now arrived to 39, including United States and Israel. And at 31 August 2021, we have already enrolled 113 cases of patients that, in spite of partial complete vaccination, have developed COVID. At present, just yesterday, I asked, and we arrived to 341 episodes already registered. And probably for the end of the year, we arrived at more than 500 cases that will be registered. These preliminary data are impressed on blood. And I show you these data because, of course, are quite different to that we observed in the preliminary observation. No difference regarding the sex distribution of the age that are quite similar. The prevalence of male, important prevalence of age over 60, and also comorbidity and smokers are quite similar. The difference are regarding, above all, the malignancy that, in fact, if you can see in this table, patients that developed this COVID in spite of vaccination are mainly lymphoma, chronic lymphocytic leukemia, and multiple myeloma. I want to underline that only 5 patients with acute myeloid leukemia developed COVID, and there is only one case, 1% of allotransplanted patients that developed the COVID in spite of vaccination. At present, we can say that if the patients vaccinated go to an allotransplant, the risk of developing COVID is very, very, very low. And also regarding the disease, in spite of a controlled disease that is highly represented in 45% of the patients, there is the possibility to develop the COVID infection. Regarding the kind of vaccination, as you can see here, the majority of the patients received mRNA type of vaccination, and there is a large number of them, near 80%, that developed COVID after at least two weeks after the vaccination. So they must be considered covered from the vaccine. Unfortunately, we have only in a few cases the anti-spike dosage that was, as you can see here, only in 32% of the patients, and only half of them is presented anti-spike that were considered protective in this kind of patients. Regarding the COVID infection, see here, 43% of the patients have an English variant. There is also an Indian variant in 24 cases, and 30% is a wild type. As also in the first phase of a survey, pulmonary symptoms represent the majority of clinical manifestation in this kind of patients. And in spite of vaccination, severe and critical COVID infection was observed in more than 70% of cases. So in spite of vaccination, the risk of an important infection there is. And the distribution of the type of vaccine and the type of a variant is clearly showed in this slide. As you can see, the Moderna or the AstraZeneca is present in the majority of centers. And the English variant is mainly of course, in England and in United States. This is the very important point. The mortality, in spite of this situation, dropped down to 12.4%. So we can consider that the vaccination probably cannot reduce the intensity of the infection, but thanks to the vaccination, thanks to the other approach that probably in the first wave and also in the second wave we haven't. Now we have. So we have a marked reduction of the overall mortality in this kind of patients. So finally, I want also underline this point that is very interesting. If you remember, I said you previously that the mortality among acute myeloid leukemia reached 40%. Now is no more than 5. There is no patients among the 5 patients with acute myeloid leukemia that died for this kind of infection. I want to also underline that the mortality in English variant is very, very important in this kind of patients. Yes, so I finish, and I want my thanks to all the people that participated in this important survey, to the steering committee, to Oliver Connolly, that was the chairman of the Infectious Disease Working Group, and to my very important friends, my younger important friends, John Salmanton Garcia and Francesco Marchesi, that helped me in all this work. Thank you.
So thanks to Professor Gorin for this kind invitation. I'm delighted to share with you some of our recent results about how the Delta variant replicates, fuses, and interacts with the host immune system. You all know that variants of concerns emerged at the end of 2020. For instance, the so-called Alpha variant was first identified in UK and was predominant for about 6 months in 2020, early 21. It has since then been supplanted by the Delta variant, first identified in India, and which represents now more than 99% of sequenced cases in many countries, such as UK, France, Israel, and USA. This Delta variant spread like wildfire. Why? This variant is estimated to be about 2 times more transmissible than Alpha, and the reasons for this include increased viral loads and longer duration of viral shedding in infected individuals. It is also associated with enhanced viral fitness in cell culture systems, as well as immune evasion properties that I will discuss soon. It is also known to increase hospitalization rates, probably because of the higher viral loads which are found in infected individuals. So why is this Delta variant so efficiently transmissible? It carries a set of mutations within its genome, including 9 mutations, which are depicted here in the spike protein, which allows viral replication. So those mutations can be classified into 3 main classes. I won't go into detail, but the first class of mutations may enhance binding to the ACE2 receptor and may enhance infectivity. The second class of mutation is this mutation, P681R, which is located here at the cleavage site between the 2 parts of the spike, and it is known to enhance fusion after viral binding to its receptor. And finally, the third class of mutations are located here and are antibody escape mutations. So that's this unique combination of mutations which facilitate viral transmission and viral spread. It is important to note that the Delta lineage is currently evolving with sublineages. For instance, the so-called AY42 sublineage. It's a Delta variant carrying 2 additional mutations depicted here. And during the last weeks, this AY42 variant seems to spread in different countries, including UK. In this country, it now represents up to 10 to 15% of the sequenced cases. So now let's talk a little about fusion and syncytia formation. Fusion or merging of the membranes of viral particles and target cells occur at the early step of the viral replication cycle and allows viral entry into target cells. But once the cells are productively infected, they may express the spike, the fusogenic spike at their surface, and the infected cells may thus fuse with neighboring cells if they carry the receptor. This will lead to the formation of syncytia. Syncytia are giant multinucleated cells which have been observed in cell culture systems. I will discuss that very soon, but also in infected patients as illustrated here. Here you have images of syncytia found in lung tissues of patients who deceased from infection. Their precise role is not fully understood, but that's precisely what we are studying. Do they represent a dead end for viral replication or a cytopathic effect, or do they facilitate viral spread from one cell to another, and do they allow antibody evasion? That's precisely what we are studying. So I will now discuss precisely how we study syncytia formation, and then I will discuss the sensitivity of variant Delta to neutralizing antibodies. So how to study syncytia formation and viral spread? We use different experimental systems. Here, I will describe one such system. This is a cell line called U2OS. So it's a human cell line, and we selected this cell because it is very flat, and this flat shape allows imaging. Those cells do not express the ACE2 receptor. So we transduce those cells to express this receptor, creating U2OS ACE2 cells. And you can see here that upon SARS-CoV-2 infection, the parental cells, they are not sensitive to infection when they are incubated with the virus, whereas the U2OS ACE2 cells become largely infected here by flow cytometry when they express the ACE2 receptor. So we also added in this cell the GFP split system. So what is the GFP split system? In this system, half of the cells will express part of the green fluorescent protein, and the other half will express the other part of this GFP protein. And once those two cells will fuse, they will generate a green fluorescent signal, as illustrated here. You have syncytia, large cells which are fused and which also express the spike protein. So we term this system the S-fuse cells, and we have designed the so-called S-fuse assay that I will describe now. So you can see here non-infected cells, and on the right panel, cells which have been exposed to SARS-CoV-2, and this is a real-time imaging of the infection process. And you can see that as soon as 3 to 4 hours post-infection, giant green cells are formed, and after about 20 hours, 24 hours, the cells will shrink, explode, and will be destroyed by the infection. So this is a very convenient system to monitor and to follow in real-time infection. So the S-fuse assay is very simple. We prepare the cells in 96 well plates, and then we can incubate virus plus, for instance, sera that we want to test with the cells. And after overnight incubation, this is a 96-well plate. You can see here infected cells, non-infected cells, and we can stain the cells with DAPI here to visualize the nuclei. And we have an automated confocal imaging system, which allows to read in less than 7 minutes a 96-well plate. So this is very convenient, and this is illustrated here. Here you have a whole 96-well plate, and we have tested here 4 sera from infected or vaccinated individuals, and we perform serial dilution of the sera. And you can see here, for instance, that sera number 3 is not inhibiting infection, whereas sera number 2 and 4 are active, and sera number 2 is active up to 900 dilution. This allowed us to calculate for each sera to be tested IC50 or neutralization titers. So that's for the neutralization. We also isolated different variants, including the Delta variant itself. We did that in April 2021, and I think we were one of the first lab worldwide to be able to isolate this variant from a traveler returning from India and who was hospitalized for COVID-19 at Hôpital Européen Georges Pompidou. And this is a collaboration with the virologists and clinicians there, including David Veyer and Hélène Perret. And we also collaborated with Étienne Simon-Laurière to make the sequence and to align the different variants that we have used. What we observed using the SFUSE assay is that the Delta variant was able to generate large or larger syncytia than the previous D614G strain or even the Alpha strain. And this is something that we are currently studying. But this indicates that the Delta variant seems to be and is more fusogenic than the previous variants. And this may explain in part why the variant is so efficiently transmissible. So now I would like to discuss rapidly how the sensitivity of the variant Delta to antibodies. We have studied its sensitivity to monoclonal antibodies, to sera from convalescent individuals, but now I will only discuss how vaccine recipients are able to neutralize this variant Delta in cell culture systems. And I will also show you the durability of the immune response. Why studying the levels of neutralizing antibodies? Because this is so far the best, if not the unique correlate of protection against SARS-CoV-2 infection and severe disease. This was illustrated or demonstrated first in animal models such as rhesus macaques or small rodents like mice. It has also been shown that the neutralizing antibody levels are highly predictive of immune protection from symptomatic infection, for instance, in this article. And I can also quote this interesting work by the Oxford COVID vaccine trial group. They tested thousands of individuals and measured the neutralizing antibody levels in their blood. Those individuals have been vaccinated with AstraZeneca, and this team was able to determine that you need to have a certain level of neutralizing antibody or anti-spike antibody to be protected, at least to display an 80% vaccine efficacy protection against primary symptomatic COVID-19. So measuring the levels of antibodies in vaccinated individuals is a good marker of protection against severe disease. Those experiments were performed here at the time of alpha virus circulation in UK and after AstraZeneca vaccination, but the levels of antibodies required to be protected against Delta might be even higher than those observed with alpha. So this is an example of our analysis. Here we have followed the evolution of the neutralizing response after Pfizer vaccination. Here, this is a cohort of about 20 individuals who have been fully vaccinated. And you can see that up to 8 months post-vaccination, while there is a peak of neutralizing antibody. This is a log scale, so the neutralizing antibody titers are very high, and they progressively start to decline. And we have tested here the neutralizing activity against an ancestral D614G strain, but also against alpha, beta, and delta variant. And you can see that the beta variant is the less sensitive to the neutralizing antibodies. And here, this is the threshold of detection of neutralization. And that after 8 months, about half of the individuals have already lost neutralizing activity against beta. And against delta, the levels are somewhat higher, but there is a trend also of waning decrease of neutralizing antibody levels. And that's why the third booster dose is recommended in some individuals and is being now implemented in different countries. We have also performed with this assay a side-by-side comparison of different vaccines. And here, for instance, this is a comparison of the neutralizing antibody titers observed after Pfizer, AstraZeneca, a combined AstraZeneca-Pfizer vaccination, Johnson, which is a single-dose vaccination, as well as Sinovac, or CoronaVac, which is the Chinese vaccine based on inactivated viral particles. So this work has been done in collaboration with virologists and clinicians from Orléans Hospital, Thierry Prazuc, Laurent Auclou, as well as with Paola Minoprio, who is a scientist at the Sao Paulo Institut Pasteur Institute, because as you may know, Sinovac is not allowed, is not authorized in France. So what did we see? So both Pfizer and AstraZeneca generated similar and good neutralizing antibodies. Here, this is 1 month after full vaccination. The combination AstraZeneca and Pfizer is even better, and this has been shown by different teams. So, but in the 3 here kind of vaccinations are highly efficient. With Johnson, which is an adenovirus-based single-dose vaccine, the levels are very low and probably not neutralizing, and that's why now people who receive the single Johnson dose are invited to get a booster dose with a Pfizer or a Moderna vaccine, at least in France. And with Sinovac, the response is not that bad against the ancestral strains, D614G and alpha, but against delta and beta, the response is very low. So probably this vaccine is very poorly protective against those variants. So I will stop here just to mention that some of these results have been published in Nature, and there are other teams worldwide which describe the same kind of results. So to conclude, I'm not an epidemiologist, but it is important to note that worldwide there are about 3% of individuals who have been officially diagnosed as being infected. This number is probably underestimated. And there are about 40% who have been vaccinated. So this means that about half of the population is naive for the virus, and there is still room for the virus to evolve and to spread, and that's why it's important, of course, to vaccinate the more and more to be protected and to restrict the circulation of the virus. So to conclude, I've shown that Delta is more fusogenic than previous variants. It is less sensitive to sera after vaccination, and I didn't have time to show you that that's also the case with sera from naturally immunized individuals. The Pfizer and AstraZeneca vaccines induce cross-reactivity against variants with slightly lower efficacy, whereas sera from Johnson or Sinovac vaccines poorly neutralize Delta. And we are currently continuing these studies by performing longer surveillance periods, studying the impact of the third dose, studying the novel Delta sublineages as well. So I would like to thank my fantastic team. They are all here standing in a meeting room at Institut Pasteur. And more especially, I would like to thank the Julien, Mathieu, Françoise, Michael, and Nell, who are working on syncytial formation and SARS-CoV-2 mediated cell fusion, as well as Delphine Plana, a talented postdoc, Timothée Bruel, Jérémy, Ludivine, Florence, and Isabelle, who are working on the neutralizing activity of the sera against the different variants. And we are lucky to have a lot of collaborations with scientists from Institut Pasteur, as well as from virologists and clinicians from different countries and different cities in France. So thank you very much for your attention.
Hello, my name is Per Ljungman, and I'm going to talk about CMV as the first topic, and then I'm going to talk about COVID-19 in stem cell and CAR T-cell patients, and I'm from the Karolinska in Stockholm. And these are my disclosures. So, starting with CMV, of course, CMV has been called the troll of transplantation and has been associated with morbidity and mortality since the early day of stem cell transplant. This is an old study now, it's from the Seattle group, looking at CMV serostatus, and if the patient is CMV seropositive, the mortality is higher and the outcome is worse. And we have discussed for many years what's the reason. It could be direct effect of viral replication, it could be CMV disease, it could be toxicity of antiviral drugs, or possibly impact of other factors where CMV contributes, such as graft versus host disease. This study came a few years ago and shed some light on this. It is again from the Seattle group, and they show that any level of CMV replication measured as detection of CMV DNA in plasma is associated with mortality. So this means that we should know which patients are at risk for replication and how to prevent it. And this is a nice study from the SFGM looking at risk factors for CMV replication in a cohort of quite recent patients. And we have the donor CMV status, the donor type, conditioning regimen, TBI, ATG, and MMF going into the model. And the modeling it both on the test cohort and the verification cohort, this clearly segregates the different risks from low to high, and this can potentially be used in designing our strategies. Looking at CMV disease, this is a quite rare occurrence today. These are the results of 4 randomized studies, and placebo arm has a low risk for CMV disease. 3 of these studies, as you can see, was done by Francisco Marti, who is on the slide, and who unfortunately died in an accident earlier this year. And it's a big loss to the community of CMV-interested stem cell transplant people. But we also know that the patients in clinical trials not necessarily represent the reality because we are selecting them based on inclusion and exclusion criteria, and that will disregard some factors. And this could be illustrated by the cube to the left in contrast to the cube to the right, where you have the real life patients. And this is in fact also the case. This is from the previous study looking at CMV replication, what the real incidence of CMV disease is over a 1-year period, and you come up to 11%. But it should be noticed that this paper was published in 2016, so it's before introduction of the Termovir. And this is, of course, the game changer for us that has happened the last 5 years. This is the randomized, placebo-controlled, pivotal study of letermovir prophylaxis given for 14 weeks in allogeneic stem cell transplant patients. The primary endpoint was at the time a novel endpoint. It was what's called clinically significant CMV infection, meaning the combination of CMV disease or the requirement for antiviral therapy. And as you can see, not only did letermovir decrease the risk for clinically significant CMV infection during the time it was given, but also for several weeks after it was stopped. And this, at least to my surprise, translated into a strong effect on reducing all-cause mortality, and particularly since you see that the curve starts really to separate after you stop letermovir, not during the time it was given, although there is a difference in that period too. When we looked at this data, it was not any clinically significant or any difference in mortality at 48 weeks. On the other hand, you can say that's many weeks and several months after stopping therapy, and what prophylaxis would have that long-term effect. But anyhow, we went in and looked in a post hoc analysis to try to correct for risk factors and see what then happened. And when we do that, and particularly corrective for acute graft-versus-host disease and also the baseline risk, there is a statistically significant difference at 48 weeks in patients who did develop clinically significant CMV infection. And it can be seen on these two curves, where you to the left have patients with clinically significant CMV infection, and to the right, those without. And of course, if your placebo patient don't get any CMV, what would then letermovir do in comparison? That's why we need to look at the patients who really were at the highest risk. So this is the pivotal study. Letermovir has been introduced in many countries since then and has been used extensively. And we are now starting to get some real life data. This is a recent study from the MD Anderson group, Roy Cemali and co-workers, looking at 537 consecutive CMV seropositive patients. CMV seropositivity is in the requirement for using letermovir according to the label. And 1 out of 23 received letermovir, and they used the standard definitions for CMV outcomes, such as in the pivotal study, and they modeled risk factors in a multivariate Cox model. And these are the main CMV outcomes. The left one we did not look at in the pivotal study. It's the risk for resistant and refractory CMV infection requiring, for example, second-line therapy such as foscarnet. And there is a very strong difference in favor of patients getting letermovir. And to the right, you have the primary endpoint in the pivotal study, clinically significant CMV infection. They also looked at the mortality, and to the left is a freedom of non-relapse mortality, and there is a significant difference in favor of letermovir. And to the right, you have predictors of non-relapse mortality, and again, it is a statistically significant difference. So the results of the pivotal study have been replicated in real life studies, and there are a couple of other studies showing the same thing now. There are a few things we need to know when we use letermovir, and one is the concept of blips, and that is low level of CMV DNA detected in plasma, particularly early after introduction of the prophylaxis. And these are believed to be so-called abortive CMV infections, and unless the viral load continue to increase, can be disregarded. And this probably has to do with the mechanism of action of letermovir, which is working very late in replication cycle on the so-called CMV terminase. And this was studied in more detail by our Italian colleagues, by Fausto Baldante and his co-workers, and they were able to, in a decently sized cohort, to see that more than 1/3 of the patients were positive at least once in blood, and almost 1/3 in plasma as well. The viral loads were low, and the earlier you started letermovir, the less likely this was to happen. And the patients did well, most of them without any intervention with preemptive therapy. So this is something we need to be aware of. Letermovir has some interaction. We have known for a long time that it interacts with cyclosporin, particularly that cyclosporin increases strongly the letermovir concentration. The effect the other way around exists, but is not that substantial. But also with tacrolimus and sirolimus. And on the antifungals, it interacts with voriconazole, but not in any relevant way with posaconazole. So this is another practical issue when you use letermovir. Early on, before letermovir was widely available, there was a possibility in France to use it for secondary prophylaxis, and this yielded some very nice data from Christine Robin, where 80 patients were treated, started late. Most patients had more than one CMV replication episode and needed preemptive therapy, and only 4 out of 80 had a breakthrough infection, and out of those 4, 3 had letermovir resistance. So it is possible to use letermovir later after transplant, after already CMV has reactivated and been treated, but of course this is off-label use. So when should we definitely not use letermovir today? Well, we should not use it to prevent primary infection. We should not use it for therapy of either CMV viremia or disease. And we should not use it in children because it is not licensed below the age of 18. Studies are ongoing for most of these potential indications. Okay, so that is what we can do up front, but we are still having a problem, at least in some patients, although it has become less commonly seen now in patients on letermovir, and that is patients getting CMV reactivation repeatedly. And it's typically the high-risk patients. We know that these patients have poor activity and tolerability of existing antiviral drugs. It has been associated with poor T-cell control, for example, severe graft-versus-host disease, use of T-cell depletion, or having a CMV seronegative donor. This mediates an increased risk for resistant strains, and it increases mortality. Of course, the standard first-line preemptive therapy has been ganciclovir, valganciclovir for a long time, and that is still the case. But in patients failing the first-line therapy, they have a tendency to run into toxicity, and then we would need better second and third-line drugs. And there we come to an old drug, maribavir, which has been around now for at least 20 years. There was a successful phase 2 study published in 2008. The phase 3 prophylaxis study failed, unfortunately, but some interesting work was done in the US by Robin Avery and in France by Sophie Alain, using it for resistant refractory cases. And it was transformed into a phase 2 treatment studies, which showed efficacy and safety. And this is the phase 3 study, not yet published, but presented both at the TCT meeting and the EBMT meetings in 2021, where maribavir were compared to investigator-assigned treatment in patients failing or being refractory or resistant to the first-line drugs. And this is the primary endpoint, conferred viral clearance at 8 weeks. And as you can see, a very strong effect in favor of maribavir versus investigator-assigned therapy. It was done in solid organ and stem cell transplants, and the efficacy was the same in both transplant types, and regardless if the patient had received foscarnet or valganciclovir as the assigned therapy. The effect was maintained to 16 weeks. Of course, in both arms, patient had relapsed in new CMV, but there was a significantly difference already also at 16 weeks. And this is probably the most important slide, showing much less toxicity, regardless if the patient had received valganciclovir, ganciclovir, then the patient had much less neutropenia, or foscarnet when the patients on maribavir had much lower risk of renal toxicity. What's the other option? Well, we can still use T cells. It's been around for more than 30 years, and we have learned a lot, but it's still something that is not readily available at most centers. You could use unispecific or multispecific T cells, and particularly the multispecific T cells are of interest because then you might be able to manage also EBV, adenovirus, BK virus, for example. We could think about using T cells from the stem cell donor, but particularly for CMV, the high risks of patients with CMV seronegative donors, and then it doesn't really work. So the major interest now is off-the-shelf third-party T cells used in clinical trials as ATMPs. So this is what I wanted to say about CMV. So this is how far we have come in CMV management. We have come a long way, and if we also get maribavir on the market, we will have 2 non-toxic oral drugs, and that will definitely help our patients, although we still have patients who fail and where we have to think about other strategies such as immunotherapy. The second part of my talk is going to be on COVID-19, and you have heard 2 talks already about COVID-19 and different aspects. So I'm going to concentrate on the stem cell transplant and CAR T cell recipients. I, in this case, represent the EBMT infectious diseases working party, and we have data from the EBMT registry. This is the results from the first wave. We published earlier this year about 380 patients, and we have since then worked with the registry to get more patients, and we have also worked in the European Conference Infection to Leukemia for some recommendations for management, including vaccinations. This is results so far unpublished of the second wave. So now we have 700 patients. Up to today, we have more than 1,300 in the registry. They are about the same characteristics as in the first publication, a little bit more than 50 years old, 44 of them children. But what has changed is that we are now getting more reports on allo patients than on auto patients. This is the updated survival for children versus adults, and as you can see, there are still very big difference. We will have a presentation on our pediatric results at ASH from Dean Auerbach, who will show some interesting data. For example, that in children, the effect is substantial on outcome if they have chronic GVHD, which we have not seen in the adults. This is the second wave versus the first wave, so we certainly have improved somewhat. Remember, we are now up till February of this year, so it is before vaccinations were introduced in Europe. And these are the risk factors for poor outcome, and I'm only looking at the allo patients because we have some doubts about representativity of the auto patients. Age remains important, performance status. We see something now on immune reconstitution, both on lymphocyte CRP ratio and ANC, and also actually on diagnosis. And these are risk factors for survival. We will continue to work on the registry data and particularly look at the impact of vaccines. This is a very recent analysis, and it's just coming out now in leukemia. This is the outcome of COVID-19 after CAR T-cell therapy. This is a joint EBMT-EHA experience. We have 56 patients, and as you can see, the outcome is very poor. About 50% of the patients succumb to COVID-19. This is patients, again, from the beginning of the pandemic to now, but we cannot really sort out an impact of improved therapy. We will see, and we'll need more patients to do that. But these are the factors associated with mortality, age, as in the transplant, performance status, as in the transplant, metabolic comorbidity we did not see in the transplant, so this is an interesting new finding, and not very surprising, disease not in complete remission at the time of COVID-19, but patients died from COVID, they did not die from relapse of their underlying disease. So what about then vaccination of stem cell transplant and CAR T-cell patients? Because that's where we have been now for the last several months in really promoting vaccinations all over. And this is the balance, the benefit and the risk of vaccination. What's the risk for severe disease? What's the potential benefit? Will the patient respond? And if there are any risks, and is there any difference in the immune response? Generally speaking, on vaccines, we have seen many quick reports with preliminary and incomplete data. There are no comparative studies, very naturally so. We have few prospective clinical trial immunocompromised patients, limited safety information, and there is some data regarding immune activation phenomena such as GVHD. This is one of the few prospective clinical trials performed by us at Karolinska. It's just been accepted for publication. It found 450 immunosuppressed patients, stem cell transplant, solid organ, CLL, primary immunodeficiency, and HIV, and 90 healthy controls, 2 doses of Pfizer vaccine, and primary endpoint seroconversion and safety. And these are the effects of vaccination, and this is the stem cell transplant cohort, and as you can see, poor response to the first vaccine, but quite good response to the second dose. This is in contrast to solid organ transplant patients, which is the worst group here, and also the CLL patients who also are doing worse than the stem cell transplants. When we split it in the stem cell transplants to patients vaccinated early after transplant, they respond much more poorly than patients late after transplant, and this has been shown in several studies. And these are the CAR T-cell patients, don't responding at all. Safety, the standard side effects are the same, maybe slightly lower. We had 1 death in a SUSAR, possibly macrophage activating syndrome, and we also see some patients with graft-versus-host disease. Our total experience at Karolinska suggests about 3 to 5% for GVHD induction or worsening, and there are similar data in 3 other reports. This is the European Conference on Infection and Leukemia, was looked at recommendations, and these are the recommendations in stem cell transplants, which also are endorsed by the BMT, that stem cell transplant patients should receive COVID-19 vaccine. We recommend to start at 6 months, considering the poor results early after transplant, if the transmission in the community around is controlled. Otherwise, you can consider to start. You have to be aware, or start earlier. You have to be aware of the risk for GVHD. The question about third dose is tricky because there are really very limited data, and we don't know if you should give 3 doses basically up front, or you should give 2 doses and wait and give another dose later. Another question that we don't know is patients coming into transplant having been vaccinated, should they be revaccinated after transplant? That is most likely the case, considering what we know from other vaccines, but there is very limited experience with more than 3 doses, and the regulatory authorities might have ideas about this. We should immunize family members at presently about the age of 12, and of course, all staff. So what do we do with non-responding patients or poor responding patients? So we could think about monoclonals or antiviral therapy. Regarding monoclonals, there are several licenses now or under evaluations. There's very little information in our patients, but it seems to be safe. This is an interesting study presented as a preprint so far, saying that patients who are seronegative before getting monoclonals have the benefit of getting them, while patients being seropositive in that group, the monoclonals do not add anything. So these are the ESIL recommendations where you can think about using monoclonals. And then you have, for example, patients with mild moderate COVID-19, patients remaining seronegative, PCR positive, those admitted to hospital but are being seronegative, and for post-exposure prophylaxis. And finally, there are things coming on the horizon. These are 2 new antivirals given as pills. It's the Merck drug, molnupiravir, just emergency approved in the UK. And this data came out last week from Pfizer on their drug, which is a protease. Both of them seeing very promising in preliminary data. So thank you very much for your attention.
So first of all, I'm Claude Gorin. First of all, I would like to thank you all three, because you gave, in my opinion, even if I have a bias, a wonderful talk, the three of you. And I have very, very many questions. We have about 15 minutes. We are late, in fact, but that will be okay. So I have my own question. I have some questions from the audience, and maybe some of you three want to ask questions to the other two. I don't know. Let me start with one, and I will start with you, Livio. When you started your talk with the first wave, and by the way, congratulations, because this is really the best survey we have so far on COVID in hematology. Well, the first wave was associated, you said, basically with a 31% mortality rate, which is huge. But then you told us, of course, that it was reduced for the second wave and then for the third wave. So I will just summarize as of today. My question is the following. What is, in your opinion, or from the data, the odds that a hematology patient who gets COVID today dies? Question one. He is hospitalized, so a patient hospitalized, what is the death rate? A patient going to ICU, what is the death rate? And a patient, you mentioned that, with mechanical ventilation, what would be today the death rate? Just 3 or 4 figures. What would you answer?
A lot of questions. Thank you, Claude. Thank you for your positive comment of our survey. First of all, I want better explain that the 31% of mortality is that we observed during all the year. And the difference between the first and the second wave is 40% in the first wave and 20% in the second wave. But the overall was 30%. So we observed a marked reduction between the first and the second wave. This is the first point. Regarding the mortality in hospital and out hospital among our patients, data that I see just today said us that the mortality in patients in hospital is 40% and a little lower for those that was out hospital. Of course, usually severe and critical patients were admitted in the hospital. On the contrary, patients asymptomatic or mild was out, and probably in these kind of patients, there is an impact very relevant over the underlying malignancy, and that have a great impact on this point. Regarding the intensive care is dramatic, the situation. As you can see, I show the data, the mortality among patients that were admitted in intensive care is near 65%, double with respect to those that were admitted in a conventional ward in the hospital, and increase again more until 75% among those that needs of a mechanical ventilation. This is the past. At present, probably we have a marked reduction in mortality, but remain relevant in these patients, the problem, above all, if the patients go in intensive care. It means that the situation is dramatic, and probably the COVID is the cause, is not the first cause, but is the cause that added to the underlying malignancy induced the mortality in this kind of patients.
Okay, thank you. So it's still, I would say, pessimistic. Then I have a question that came. I think one of you may believe you did answer, but I would like also to listen to the answer by Olivier Schwartz. So I'm reading the question. And I think the person who is asking the question has some logics. So Olivier, I think it's for you. Every 6 months, more or less, we have a new variant that becomes predominant. Could we predict by the analysis of circulating variants which one will become the next predominant one? Is this a fair question? What's your opinion, Olivier?
Thanks, Claude. Well, I think this is totally a fair question. I think it's very difficult to answer, but thanks to the GSED survey, in which you have millions of sequences which are continuously added, it's very easy to see the trend and to determine whether one variant is taking over and is spreading more rapidly than another. It's difficult to predict, but now I think there are a few hotspots, especially in the spike, which we know may confer some different kinds of improved properties to the virus. And when they are combined, they might increase transmissibility, especially among people who have been vaccinated or who already have antibodies after natural infection. And it is also interesting to note that there are recent articles describing mutations in other proteins, in other viral proteins, especially the nucleoprotein, the nucleocapsid, which are associated with increased transmissibility. So it's important to extend the analysis to the whole viral genome to identify the strains or the lineages which will spread more rapidly. So it's difficult to predict what will happen in the future.
But I get from your answer that, in fact, it goes in the direction of being worse. I mean, the trend is in the direction or more efficient viruses, resisting viruses, and more viral shielding, as you said, shedding. Not shielding, shedding.
Yes and no, because if the number of vaccinated individuals increase, this reduces the circulation of the virus, and that's this strong circulation which is associated with the appearance of novel variants or lineages.
Okay. So I have a second question for you, which I received, I must say, before even our webinar. It's about new vaccines. I'm surprised, and the person who asked the question also is surprised. There is no appearing a new development is this new wonderful vaccine, RNA vaccines. And what's the future? I mean, isn't it possible to imagine a different vaccine not only targeting the spike protein, but maybe targeting another protein or another epitope? And also, what about the inactivated entire virus? One could say, for instance, that it might be more protective because it should be, at least in theory, active against other targets and not only the spike protein. So what do you think, and what is for you the future of our vaccines?
So far, the current vaccines remain efficient, even if the vaccine efficacy decreases over time. So there are, I know that Pfizer has started, for instance, to include other spike sequences in their vaccine preparation, but it is not necessary at this stage because the current vaccines remain active against the variant, even if there is a decreased efficacy. And regarding other epitopes than the spike, so we know that the best correlate of protection is antibody levels against the spike, but that's obvious that cellular immune responses are important as well. And in the inactivated virus strategy, of course, you can imagine that you would generate antibodies or against other proteins, and that's true that after Sinovac and CoronaVac, it is possible to detect anti-N antibodies, but as so far they are not known to play a protective role at all. And we know that the inactivated virus vaccine strategy with this virus seems to be much less efficient. That's what I showed you in terms of antibody levels and vaccine efficacy in the field, by the way. And I know also that Sanofi Pasteur is using, and there are other companies as well are using recombinant protein-based strategies, and they are including spikes from different variants in their preparation. So that will be interesting to see their results.
Okay, and before going to you, Per, a last question for you, Olivier. How can we combine the fact that the vaccines in general are effective, as you said, so you are not so pessimistic, and on the other hand, the convalescent plasma is not so effective as we thought it would be essentially in the beginning? So suppose you have somebody who recovered from the COVID with a high level of antibodies in his or her plasma, and convalescent plasma is not working in other patients. How do you explain that?
Well, there are two questions in your question. The first is the use of antivirals in general, including plasma, monoclonal antibodies, and the novel antivirals. It is known that they work when they are administered early, during the first 5 days of diagnostic, and then they work pretty well, and I'm sure that's also the case for the convalescent plasma. That's the case for monoclonal antibodies. And regarding convalescent plasma, it's not an homogeneous product. I know that multiple plasma have been mixed together, but there might be differences between lots. And some might have higher neutralizing antibody levels than the others. So I'm not sure this strategy will be continued in the future because of the monoclonal antibodies and because of the antivirals. And we didn't discuss very precisely the fact that in some individuals under immunosuppressive treatment, at least in France, they receive monoclonal antibodies as a preventive strategy. And as far as I know, they don't receive convalescent plasma.
Okay, thank you, Olivier. So Per, I'm very happy to see you again. We have worked together for many, many, many years. So I have a few questions for you. Well, there is one which comes immediately from the audience, the blips. First of all, you are really the international expert on cytomegalovirus. I can attest. This story about blips, was it seen also for other viruses under treatment, or is it specific to CMV and letermovir?
That's a good. It's a good question. It has been, we don't have really that many good antivirals for other viruses than CMV that you're monitoring this way. We don't have it, for simplex and zoster. We don't basically see any reactivations on therapy, and EBV you don't have an antiviral, and so on. So that means that there really is no good parallel. When we have looked at it with other antivirals for CMV, the answer is no, we have not seen it. There's been some discussions early on when we did the prophylaxis study with maribavir if this could be an issue. But on the other hand, that study failed so miserably. So, that's a completely non-parallel situation. Theoretically speaking, we cannot test this in any other circumstance because letermovir is extremely human cytomegalovirus specific. It doesn't work against any other virus, and it doesn't work against any animal CMV. So we cannot test this abortive viral infection hypothesis in an animal model either. So I think the best guess is that it has to do with the fact that it works very late in the replication cycle and allowing some earlier replication DNA to leak out. The good data supporting that is, of course, the Italian data where they see a difference. If you start immediately after transplant, you see it much less than if you start later. That means that the virus probably has started to replicate a little bit, and then you come in and intervene and you see the blips.
Okay, so we'll try to remember these blips because it's new. Let's say that it's a new discovery for us. The other question, well, it's simple, but I guess I know the answer. But anyway, I mean, what about the combination in our patients in hematology of CMV and COVID? Is there anything to mention, or just it's more severe because it's two infections? Is there any synergy between the two viruses or something to say?
No, I wouldn't say so. There is some data with COVID and fungal infections, and it has been certainly shown, for example, in India, where they have seen a lot of mycomycosis and aspergillus and other molds. We haven't seen the combination of CMV and COVID as a problem. It might have to do also with the timing. Most COVID cases have occurred after the peak CMV period because the early CMV patients have been more careful, they've been more protected early after transplant. And we were actually unable to see a strong time effect. But I doubt it. It's an RNA virus, it's a DNA virus. The CMV is very significantly correlated to immunosuppression. We haven't really seen that so much with COVID in the allogeneic stem cell transplants. We were in the EBMT unable to see an effect of GVHD in the adults. We are starting to see a little bit effect, as I showed, on low neutrophil counts, but that's not the time when you have CMV. So we don't have the data.
Okay, and maybe one last question to both Livio and you, Per. In fact, the incidence, the efficacy of the vaccines is much lower, if I understand well, in lymphoid malignancies and essentially people who did receive rituximab. You also, Livio, mentioned hypomethylating agents, but that's also MDS. Wouldn't these two categories be really the worst for the vaccination? So maybe you, Per, first, and then Livio, because I have a last question which just popped up for Livio. So Per, what do you think?
it's very difficult to say. If you look at the previous data, and Livio certainly has been very more into this in non-transplant patients than I have, it's clear that CLL, myeloma, rituximab treated patients, CAR T-cell patients, which basically are completely lymphoid malignancies, have done much worse. And they also respond poorly to the vaccine. Patients are now coming in, and the patients are coming in are the ones who have not have vaccinated but not develop any antibodies. The myeloid, generally speaking, MDS is of course a very mixed bag of from high risk to standard risk to low risk patients, and I think it's probably has to do with the immune response to the virus, but that's a guess.
Okay, and
Completely agree.
a comment?
Completely agree with Pierre. The problem probably is that in myeloid malignancy, acute myeloid myelodysplastic syndromes, myeloproliferative disorder in general, seems to have a better response to the vaccination with respect to those that receive the immunosuppressive against B cells as lymphoma or myeloma. So this is a very important point, probably in this kind of patients at present, but we must wait large number in order to confirm this first appearance that we have from our data is confirmed. But it seems that in this kind of patients, the risk of developed the infection in spite of vaccination is higher with respect to myeloproliferative disorders.
So, yes, so basically you both agree. So the last question, because it just popped up, Livio, it's a technical question. Somebody is asking, what are some of the challenges you encountered when carrying out this study? So how difficult was your study?
Not some, a lot of problem. Take in consideration that there is 132 centers that participated. Only administrative engagement with the ethical committee that was quite different in the different centers. It's not difficult to collect the data because all the members that participated to the study are wonderful, but all the administrative was very difficult in order to reach a complete information. And also there is the problem that not all the places are the same, of course. The approach is quite different in Europe and in Asia or in South America, because we have centers from South America and from Asia. And so a lot of changes, but at the end we reach a very interesting results, I think.
Okay, and congratulations for your paper in Blood. So I think we are at the end of our webinar. I want to thank you three speakers, really. I'm very grateful that you accepted to be with us today. And I want to thank the technical team of CME Congresses. I think they are very efficient. So I will leave now and say bye-bye to all of you, and maybe see you someplace else or at another webinar. Thank you. Bye-bye.
Thank you. Bye-bye.